This is Dr. Jamie Kaufman, and this is Dr. Kaufman's Acid Reflux Hour. And today's topic is, I'm having light problems. Today's topic is misconceptions about acid reflux. And as I thought about this last night, I probably should have called it things you should probably know about acid reflux. So let me begin by saying there are some big ones. Acid reflux is not just about acid, it's also about pepsin. And the idea is to get rid of pepsin in tissue. Pepsin is an enzyme in the stomach. It causes all the inflammation. It actually causes cancer. It is bound to your tissue when you have reflux episodes, and then subsequent reflux episodes, delivering acid or drinking it, activate pepsin. So pepsin needs acid to activate it, and it's all about pepsin. And if you look at my blog, read the post on what is pepsin. I think you'll find it very interesting because it's really the name of the game is pepsin. The second thing, and by the way, this is such a big topic, I actually made notes, and the second big idea is that most reflux is silent reflux, and I'm going to talk about symptoms in a minute. But that means most people with reflux don't know they have reflux in that they don't have heartburn or indigestion. And for that reason, silent, and they don't necessarily wake up in the middle of the night. So how would you know you have reflux? It's silent nighttime respiratory reflux. That's what about 100 million Americans have. And some of them have sinus disease, and neither they nor their doctor know it's reflux. Some of them have asthma, and neither they nor their doctor know it's reflux, the underlying cause, and so on and so on. The third thing you need to know is the gastroenterologist can't help most of you. Gastroenterologists are into esophageal examinations and heartburn and indigestion. When you start talking about LPR, now we call respiratory reflux. LPR is too small a term, laryngopharyngeal reflux, respiratory reflux. Once it gets above here, it can be anywhere in the respiratory system. The gastroenterologists don't know anything about respiratory reflux. They have no test for it. And seeing a gastroenterologist if you have respiratory reflux is probably not a worthwhile activity. The best choice you have is an ENT or otolaryngologist. The problem with that is that even the go-to doctor is the GI for reflux, but if the GI doesn't know about respiratory reflux, why should it be in the curriculum of the ENT or the pulmonologist, the lung doctor? So this is a huge black hole, respiratory reflux, and it is the reflux of today. And the final thing I want to say in terms of big picture is that a reflux is not a medical problem. There are some questions about, how wonderful surgery is and it saved people's lives. And I have no question that that's true. But it's got to be less than 1% of people with reflux. So there are people who should have surgery, and if you look at my blog on bronchitis, you'll see he was one of them. And but you can see people who've had reflux and then had surgery and then still have reflux because their diet and lifestyle is so poor. So when I say it's not a medical condition, what I mean by that is, in essence, there is no doctor or procedure that can cure reflux unless you have a part in modifying diet and lifestyle. So for the person who asked the question, said, I'm so wrong about diet and lifestyle that surgery will fix it, let me point out to you, I had a very, outgoing man who worked on Wall Street, and he had surgery, and I didn't recommend the surgery. He had the surgery, and then he came back to see me subsequently, refluxing like a bandit. And he went to Keen's Steakhouse at 10 o'clock for dinner. He had 2 cocktails. He had a ribeye steak. He had the asparagus with the béarnaise sauce, the fully loaded potato, 2 glasses of wine, and a chocolate dessert. So there's no treatment for that. That person is going to reflux all night, every night. Not 99% of the time, 100% of the time. So all I'm saying to you is that surgery will be very effective, but only in patients who have already taken all the other steps and taken them properly. And you got to know what those steps are. It is interesting. I'm going to provide with you some information And this has been the case in my practice for the better part of 50 years, and I have no idea how to explain it. But of people with reflux that I see, the ratio of female to male is 2 to 1. So for every man we see 2 women. The other thing you need to know, is just going back to the idea of the gastroenterologist and the GI model, is at least 80% of people with respiratory reflux. And by the way, for every person who has heartburn and indigestion, there are 10 people who have respiratory reflux. So they've never had heartburn a day in their life. You say, well, what's heartburn? And they don't know. So there are some people have both GERD or esophageal reflux and respiratory reflux, but they're a minority. So what's evolved today is respiratory reflux. It's almost cultural. Our big meal of the day is the relatively late refueling meal, often with alcohol and so on. I wanted to talk to you about shortness of breath. I'm in the process of doing a study, basically correlating all the data that's coming in as I do consults. And I looked at the data, and I found that number one symptom by far was postnasal drip. And postnasal drip isn't allergy. Allergy is thin. It's usually associated with sneezing, runny eyes, and it never gets on your vocal cords. It's never thick. Trying to get that mucus off your vocal cord. That's thick mucus. That mucus comes from reflux. And, of course, the respiratory tract is lined with mucous membranes, and when irritated, you get more mucus. So the number one symptom, postnasal drip, chronic throat clearing. But the big surprise was that 50% have shortness of breath. So when I'm doing a consultation and I see circled shortness of breath, I say, well, let me ask you something about that symptom. Really, I see at least 3 types of shortness of breath. The first type is exercise induced. You go up 2 flights of stairs and you're huffing and puffing. It shouldn't be. Just 2 flights of stairs. That's exercise induced. And the second type is having trouble getting air in or out or both, and that's things like laryngospasm, choking episodes, and asthma. And the third, I hope long after I'm gone, they call it Kaufman sign, because we have seen this now, and I've tried reporting it, but it's not the kind of thing you can report. Difficulty or discomfort taking a full breath in is absolutely associated with respiratory reflux. And by the way, all of these people have normal chest x-rays. So it's not like there's lung disease that's going undetected. But the inability or the discomfort taking a full breath in, people describe as shortness of breath, and it's not asthma. And by the way, anything trouble breathing in isn't asthma. So the first thing you need to know is that if you don't have prolonged expiratory phase with wheezing, that's asthma, and everything else is pretty much reflux. It turns out that exercise-induced, and a lot of people have shortness of breath, have more than one. Choking episodes are about 25%, including laryngospasm. Exercise-induced shortness of breath is about 50%, and the Kaufman sign, or inability to take a full breath in, is 75%. So that's a lot of you. So it's almost, there's a word in medicine called pathognomonic, and what it means is this sign is characteristic of this and only this diagnosis. So difficulty taking a full breath in my opinion, is respiratory reflux, and it's probably vaguely mediated because the chest x-ray is normal. The other symptoms are not heartburn and indigestion either. A sensation of a lump in the throat and difficulty swallowing. I've put up this blog today, and by the way, if you would, please sign up for the blog. You put your email in. It's never shared with anybody, and you just get an email with a topic each week, and if it interests you, you can open it. I did one recently on ginger that apparently was interesting to people. A lot of people opened that one, and this is on dysphagia, difficulty swallowing. Turns out the 2 most common causes of difficulty swallowing are the upper valve misbehaving, closing in the middle of the swallow, that's not right, and esophageal dysmotility. The gastroenterologist will want to get manometry and put you on a prokinetic agent to make your esophagus work better, but in reality, people who have dysmotility 99% of them, it's because of reflux, and if you fix the reflux, the motility will return to normal. So the dysmotility doesn't cause the reflux causes the dysmotility. Difficulty swallowing, laryngitis, voice problems, particularly, most of us are professional voice users. By far the most common cause of hoarseness is reflux, silent reflux that occurs at night. And by the way, as an aside, if you read my last post on alkaline water, you'll see these little bottles. Alkaline water is very useful, but it never gets on your vocal cords. When you swallow, you clamp your throat shut and to protect against aspiration. But if you take your alkaline water, pH 9.5, and lower your tongue, you can spray your vocal cords. A lot of people on Broadway carry these. I think this is sort of a thing on Broadway now. And it's very useful, and it helps, especially if you're doing 8 shows a week. So you can kill pepsin. Pepsin dies at pH 8, and this water is 9.5. In regard to alkaline water, try to get one that doesn't have a phosphate in it. The biggest one you see everywhere is made by Coca-Cola and has phosphates in it. So just look for one that doesn't. To my sort of read back from what people tell me, people like Trader Joe's and Alka-10. I also did a post on the drops. You can buy drops that will make alkaline water, and some of them seem to work quite well. So the whole point of all this is, the biggest misconception is reflux is not some big guy you see on television sitting on a sofa with a big half-eaten submarine sandwich, maybe a Philadelphia, one with all the cheese and all the meat, and leaning back, clutching his chest and groaning. So that ship is pretty much sailed. We don't see that many people like that anymore. Instead, we see people with all the symptoms that I've mentioned. And besides laryngitis, there is chronic cough and sore throat. And the sore throat also should be clarified. Is it raw, like you're going to get an infection? Is it sharp pain, or is it burning? And each of these things have different implications. It's usually a raw throat with reflux. Coughing, when bending over, after meals, and lying down are almost always reflux symptoms, whereas neurogenic symptoms are talking, speaking, going into air conditioning, and so on. So now we get to the question of diagnosis and misconceptions. And the first misconception I've already alluded to, which is the gastroenterologist has no test for respiratory reflux. To my knowledge, I'm the only one who had first-rate technology. I put a high-quality pH probe just behind the larynx, and we measured the pH and measured laryngopharyngeal reflux, then now respiratory reflux, in thousands and thousands of people, and got data that was correlatable to each of the things we're talking about now. ResTech is a technology where they stick something in the nose. I've looked at some of the data. It's profoundly inaccurate. You can have reflux and it's normal. You can have no reflux and it's so I don't like the ResTech technology. I'm not sure it's valid. And the GI has nothing. Having a Bravo test, if you have respiratory reflux, isn't much use either. I say, well, you have to have reflux in the esophagus for it to get up to the pharynx, but the reality is it can be missed. It can be a single one time when you lie down at night. It can be 2 o'clock in the morning. It can be one episode that sits in your pharynx, in your throat all night long, and it's easily missed. And I did impedance pH testing myself for 4 years and found it to be not very accurate. So we now have a situation where there essentially is no diagnostic test. The best we have, in a way, is the old-fashioned one that I abandoned in the late, 80s, which is barium swallow esophagram. And it should be done upright, standing, in supine, lying down, and it'll show whether you have dysmotility. If you have misbehavior of the upper valve, you may have something called a cricopharyngeal bar. And if you have reflux going back and forth freely after you've done everything that's supposed to be done in terms of diet and lifestyle, you're the one who's probably going to need surgery. Diagnosis is funny because I'm looking now to write a book, which is essentially all the stuff that's on my on my blog plus. But in essence, we spend $1 trillion a year to get sick. When I grew up, there was not an obesity epidemic. There was one fat guy. There was not an asthma epidemic. There was one kid who had allergies and walked around with Kleenex and an inhaler. The same thing. There was no sleep apnea. All of these diseases have occurred. 25% of the American diet is fast food, and so our diets and our type of diet, not only, but when we consume it, late night eating, being the number one reflux factor, respiratory reflux factor. So we then spend another $1 trillion on ineffective treatments. So people ask me all the time about the magnets, the links, and the EndoCinch, and these devices that people are putting on, and none of them work. Okay, when push comes to shove, maybe they'll help you for 6 months, a year or two, depending. But in essence, if you're going to beat reflux, it's about diet and lifestyle, period. Now, going back to the question of surgery, if you have surgery and you have a reasonable diet and lifestyle, that may do it. But again, that's 1% of the population that I've seen, about 100,000 people with reflux over the course of my career. Biggest misdiagnoses are asthma, sinus problems, and allergy. Remember, allergy is a thin mucus. It doesn't get on your vocal cords. I'm having terrible problems with the sunlight. Now treatment goes back to the question, it really isn't a medical problem. So I broke my hip. The captain of my ship was my orthopedist. You have respiratory reflux. You are the captain of your own ship. You're not going to find a doctor or procedure with a pill or a better procedure that's going to make it go away. So if you're insistent upon stopping at McDonald's on your way home from soccer practice with your kids at 8:30, and everyone goes to bed early, including you, you're going to have reflux all night, every night. And reflux is if you will, a vicious cycle going down. The more you reflux, the more the lower esophageal sphincter becomes stiff and swollen, the more you reflux, and then dysmotility, a lazy esophagus occurs, and finally the upper valve kicks out. So when you lay down, what's in your stomach is in your esophagus, in your throat. Now, all of those things mean that you're looking for information about diet and lifestyle. I have bad news for you. 98% of the information on the internet is wrong. Dead wrong. Dead wrong. Okay? If you have pepsin stuck on your vocal cords and in your throat, lemon, anything acidic, we recommend a high pH, low-fat diet. This is proved and stood the test of time now for thousands and thousands of patients. So having acids makes no sense. Biggest misconception number 2 about that is that people don't have enough stomach acid. Oh, I don't have enough stomach acid, so I take acid. There's no such thing as not enough stomach acid. So if you have not enough stomach acid, you have pernicious anemia. It's an autoimmune disease. It's rare, but everyone else has enough acid. How do I know that? Because we did pH testing, I don't know, thousands of patients over the course of 30-something, maybe 40 years. And the first thing we do is put the probe in the stomach, and everyone has, pH 1 or 2 or even less acid in the stomach. It's not a question of quantity. So everyone has acid. So I just would summarize and say the biggest risk factors for reflux are eating too close, snacking, or meals to dinner to bed, and alcohol. For half of my people who fix their reflux, for half of those, after everything's settled down, they can drink modestly. But for half of them, the night you have a cocktail or a glass of wine, you're going to reflux at night. So that's pretty much what I have to say about misconceptions. There are many more, the smaller ones. For example, I wrote an article recently on famotidine, which is Pepsid, the generic of Pepsid. And the reason I wrote it was to get back to this question of the internet being full of nonsense. apparently someone, I don't remember the art, it was a medical thing like Medscape or one of those that writes articles. Someone decided they would go through the internet and find all the different things that people said caused problems for them, and then said they were all side effects. None of them are side effects. So I wrote an article on famotidine, and there is a question here which I'll address, and I can't remember who said it, because it's in here somewhere. But she says, "Oh yeah, my mouth is dry enough on my own, but I hate taking the medicine; it makes me drier." So one of the side effects of famotidine is that it can dry you, but not usually by itself. You're taking an antihistamine for something else, or you have Sjogren's syndrome in which you don't have enough saliva. This is relatively common. It's an autoimmune disease against your own salivary glands, and people who don't have enough saliva have reflux, and taking a medicine that makes it dry is probably not the greatest thing you can do. So let me go and talk about some of these questions now. I think I've presented the misconceptions more as things I think you should know about reflux. But just remember, if you don't have heartburn, indigestion, and you don't wake up in the middle of the night, you still have silent reflux, most of you, and you have other symptoms. And the other symptoms may be related or directly caused by respiratory reflux. I want to mention again, I've written the blog for you. It's big. It has, I don't know how many articles now. You can use the little box you can write in the topic. So you can put hiatal hernia, and up will pop an article on hiatal hernia. So please, all of you, use the blog, because many of the questions that I'm getting are redundant questions that are repeated over and over and over each month, which have been answered several times in the blog. So, how do I taper medicine when my reflux is gone? Janet. So Janet's been good. Her diet and lifestyle is good. She went through a detox program. She figured out that she's got some trigger foods. She doesn't eat onions anymore. She doesn't drink white wine. And she's doing fine. She doesn't have chronic throat clearing. But she's been on Gaviscon Advance after dinner before bed, and she's been on famotidine now, and it's been almost a year. Well, so she takes one in the morning, one before dinner, and two before bed. What I recommend is decrease the dose by one pill every 2 to 4 weeks. And the one you give up first is you go from the bottom up, is the breakfast one. And then 2 weeks later, the one before dinner. And then 2 weeks later, one of the ones before dinner, and then finally both of them, before bed, and then finally the two before bed are gone. So it takes a while to do that. And the reason why you choose to do it that way is if coming off the medicine you start to have a recurrence of symptoms, you'll know. And the other thing you need to know is that for good people who get through their reflux and get it under control, especially if you live in a city like New York where there's a lot of action, often at night, a lot of people that I know, they do the detox program, they clean it up, and then they slide slowly down back into the abyss, and then sure enough, the next year they do another detox, and just a dry January is not enough. It's a detox program. And of course, if you type in reflux detox, it'll come up on the blog. Is there a best alkaline water that you recommend, Suzanne? The answer is there isn't. I do recommend, again, not one with a phosphate. Essentia is made by Coca-Cola, I believe. It has phosphates in it, and I think it has it burns some people's throats. Better to have as few chemicals as possible. But I do recommend the pH of 9.5, and again, the drops work. There's an article on pH drops. People like Alka-10, and people like Trader Joe's, and people are now coming up with a slew of different brands that I've never heard of. As far as I'm concerned, they're all fine, unless they have phosphates or funny chemicals in them. I have nausea since I was on antibiotics, and my reflux got worse. So one of the things that happens, I wrote an article on H. pylori 2 weeks ago. Most all of us have H. pylori. 100 years ago, it was associated with duodenal ulcers. The duodenal ulcers have sort of gone away. We don't know whether it's about diet and lifestyle or supplements or why, but we just don't see them very often. And it doesn't cause much of anything else. Really, the data on H. pylori is that if you treat H. pylori, you're liable to make your reflux worse. So a lot of the people that I've seen over the course of my tenure as a reflux person, reflux doctor, said my reflux got worse after I had my H. pylori treated, or my reflux started after I had my H. pylori treated, or my reflux started or got worse after I was on antibiotics. So some antibiotics are better than others in terms of reflux, and the ones that are least likely to cause reflux are the ciproflox, the Cipros, and the Z-Pak, and the amoxicillins and the traditional ones seem to cause more reflux. Next question. Most people, including doctors, don't know about pepsin. How do I get rid of it? And the answer is you need to do a detox program. You got pepsin on your vocal cords, in your throat, who knows, in your lungs. So it can be anywhere. And pepsin is a molecule that, if you look at my last article on alkaline water, you'll see it will show pepsin in the tissue on a biopsy, and it looks like it's pretty aggressive, and it is. The spray will help on the surface. But getting rid of pepsin means stopping reflux cold for long enough for it to heal. If you could stop your reflux with a magic wand, it looks like washout takes about 3 weeks. And that's why we recommend a detox program that's 4 weeks. Belching or burping, is this reflux or pepsin? Belching is, for most people, is just aerosolized reflux. The lower esophageal sphincter opens and up it comes. So it's just another manifestation. You've mentioned you can have chamomile tea before bed. By the way, chamomile tea, if you're hungry and you're more or less fasting late, chamomile tea or ginger tea. I've gone back. I did an article on ginger recently. I've gone back to ginger tea. I bought a big piece of ginger root. I cut myself 3 little slices. I put boiling water. I cover it. 10 minutes later, I put a sweet and low in. It's delicious, and it's very good for reflux, and probably other things too. Ginger has a good PR. But the question here is, what about water? Can I drink water? And the answer is you can drink water. I just recommend you don't tank up. The whole idea is to go to bed with an empty and quiet stomach. And so you don't want to turn on, the reason you can't have sugar or honey at night is because the sugar turns on insulin, and the glucagon can turn the stomach back on. So we want to go to bed with an active stomach. Water is fine. Virginia wants to know any major side effects with Gaviscon, and the answer is no. It's the most popular reflux remedy in the world. I recommend Gaviscon Advanced because it's the only one we've studied, and dollar for dollar, it's surely the cheapest one. There are other newer ones. I don't know if they're as good or not. Reflux Raft, Reflux Gourmet. Right now, something interesting happened. I wrote an article on alginates in January, and it looks like the world's supply sort of sold out because you can't find 500 ml bottles of Gaviscon Advanced Aniseed right now. You can find 150 bottles, 2 150s. It's about the same as 500 used to be. So hopefully it'll come back online soon, and they'll find some more seaweed and make some more Gaviscon. This one I don't know how to respond to, and I'd like to mull it over. I just saw this morning. My respiratory reflux symptoms are always worse with empty stomach, never after meals. How is that possible? And the answer is, if you have if you've had reflux long enough that you have no functioning lower esophageal sphincter, any activity could trigger it, whether it's how you sit down in a chair, so I don't know the answer to that, but respiratory reflux symptoms are usually not seen during periods of relative fasting. Here's the one that this is a Iona. She said, "Why are you saying surgical procedures don't work and surgeons do it for profit?" That's not true. Not those surgeons. I know people who struggle with severe reflux. Nothing worked. Diets. The only game changer was surgery. Well, look at them 5 years later. If their diet and lifestyle is bad, they'll be back to square one, and they're not having surgery again. So you can't eat late, even if because what happens is if you have reflux at night, what happens is the wrap, which used to be a little valve, now it's a big fat valve, gets inflamed and stiff and swollen. So I'm not arguing with surgery. I have had many patients I referred to surgery, and if you do recommend surgery or have recommended surgery, you can ask the surgeon questions like, how many of these have you done? And the answer should be at least 200. I've asked one of the world's leading authorities on this, what is the learning curve? And it's 200 for laparoscopic fundoplication. But it's the only operation I ever recommend at this point in my career. So I'm going to have to wind up. This question comes all the time. What's the best suggestion to keep reflux minimal when I travel to Europe next month? And the answer is, if you are going to go to Italy or Spain and live the lifestyle, you're going to have terrible reflux, but you can do some things. You can take famotidine with you. You can get Gaviscon in Europe almost everywhere. And you can do certain things. So you can minimize your drinking. You can make sure you don't have the highest fat. Don't have the lamb. Have the fish instead. So you can do things that make sense to minimize it by proper choices. So anyway, this has been Dr. Kaufman's Acid Reflux Hour, and you can ask questions, and I'll try to pick them up for next month's session. And please look on YouTube for this. And for these different topics, and also sign up for the blog.